This computer. All right, we're good to go now. Awesome. Sorry about that. All right. So good morning. Thank you all for joining our third and final webinar, The Benefits of Practicing and Integrating Food as Medicine. My name is TQ Davis, and I'm the Senior Advisor for McLane Health Solutions. And today we are talking about the benefits of implementing a food as medicine model into programs and services. And so we've mentioned this in previous webinars, but recently President Biden hosted the White House Conference on Hunger, Nutrition, and Health to push action for the millions of Americans struggling with food insecurity and diet-related diseases like diabetes, obesity, and hypertension. The conference helped to start the conversation for some, but also it highlighted the important works of others. So, of course, we know there is an increased need to try, to research, and experiment with the use of food as medicine interventions to prevent and manage and treat illnesses in response to the epidemic of diet-related chronic diseases. And according to a published article in the BMJ, 1 of every 5 deaths across the globe is attributable to suboptimal diet, more than any other risk factor, including tobacco. Research supports that food as medicine programs and interventions can help manage chronic disease and combat food insecurity. Individual interactions with the healthcare system, human and social services, and public health organizations are important opportunities to offer evidence-based food and nutrition interventions. So the question we pose today is, how can organizations and medical professionals incorporate this tangible benefit of making food a fundamental part of prevention? So we have an array of experts who would help us provide some answers to these questions. And I'm so excited to have this conversation with these ladies. So today we have Dr. Tiara Jackson, Ms. Ashanti Jefferson, Dr. Mary Wilson, and Dr. Jasmine Moore. So I'm going to ask our panelists to introduce themselves and describe some of the work that they're currently doing, and just give us a little bit of thoughts of what you think and how about the food as medicine movement. So I'm going to start with you, Dr. Jackson.
Thank you. And I do apologize. I've been under the weather, so my voice is a little scratchy. But I am Dr. Tiara Jackson, research scientist at NORC at the University of Chicago, and I'm based in Bethesda, Maryland. And my work has centered around understanding the influence of food insecurity and a lot of other social factors on child well-being, access to food, but also understanding how it affects the family dynamic around food and food-related behaviors. I've also done a lot of work around evaluating community-based programs that are focused on reducing and preventing chronic diseases such as hypertension, diabetes, et cetera. In my current role, I do a lot of evaluation-based projects working with clients at mainly the federal and also state and community levels to help them build their capacity to evaluate their programs, so helping them to understand what impact their programs are having and how to improve the work they're doing. And as far as the food as medicine movement, for me, I think it's important because diet is so closely linked to our health. But I think for far too long, we have ignored the social determinants and the reasons why people may not have access to healthy food. And so I appreciate this movement bringing light to not just recommendations for healthy eating, but also supporting individuals and families and communities at accessing food that can help improve their overall health. Thank you.
Thank you, Dr. Jackson. And we're going to dive into a little bit more into the research component. So we're going to have Ms. Ashanti Jefferson just do an introduction.
Good morning. Thank you for having me. My name is Ashanti Jefferson. I manage the wellness program at Baylor Scott & White Health Plan in Central Texas. And my team, which primarily focuses on our commercial membership, connects our members with education opportunities as well as programming throughout our system so that we can work on preventing and treating some of those chronic conditions that you referenced earlier, TQ. I think the importance of the food as medicine movement probably was highlighted for me really early on as I was an athlete. And so I could automatically see what I was eating was affecting how I was performing. So knowing that I had access to really anyone that could help improve that status, it really highlighted when I could see individuals that weren't connected to those things. And then taking it a step further, having a grandparent who had chronic kidney disease. So having to look at how food impacted her situation and having to make those changes. So food as medicine has been a really, really big part of my life over time. And in our health plan, we've been working to kind of connect the dots on some of those social determinants of health for our Medicaid members and how we can improve overall status. So thank you.
Awesome. Thank you, Ashanti. And thank you for sharing a little bit of your story. I think real life experiences has a way of touching people and moving people in a certain directions, and especially from a professional perspective. Thank you for sharing that. All right, now we're going to have Ms. Jasmine Moore give us a brief introduction.
Hi, everyone. My name is Jasmine Moore. I am the Manager of Medical Affairs and Research at PAC Health. I am a pharmacist by background. And at PAC Health, we provide a digital engagement platform that integrates personalized health coaching with evidence-based content. And in my current role, I coordinate and oversee research projects in the cardiometabolic space, such as those relating to type 2 diabetes and food insecurity. And I've also worked on projects that involve reaching members with complex or rare conditions who tend to experience more barriers to care, such as those with lupus or other rare diseases. I was also introduced to food as medicine quite early, actually through my school curriculum, as food and the medications that you take go hand in hand. It's something that we counsel patients on all the time. But with this new attention to this movement of actually educating patients regarding how to use food within their chronic condition, we've been able to have a better opportunity to focus on holistic health and really get down to those social determinants of health and barriers that patients experience on a day-to-day basis. So I'm very excited to share and learn with the other panelists.
Awesome. Thank you, Ms. Jasmine. And last but not least, Dr. Mary Wilson.
Good morning, everyone. My name is Dr. Mary Jones Wilson. I am a research assistant professor at the University of South Carolina's Honor School of Public Health. And currently I manage 2 federally funded projects through the National Institutes of Health that focus on chronic disease prevention in African Americans, by nutrition education and working with participants to help them improve their lifestyle. So a part of that work is heavily focused on our classes, our intervention classes that we conduct with our participants, and we utilize a teaching kitchen to do that. So with that, every session that we meet with our participants, the goal is to prevent chronic disease through nutrition. And so the classes that we hold with our participants are focused on healthy eating, active living, stress management. And so each class, they are participating in a cooking demo, sometimes just watching it live, other times also participating in hands-on lessons and gathering that nutrition education as well. So with my story and my background, I came to be a part of this work. Started very early on for me. My grandfather was a farmer. I did a lot of work in the past before working in the research environment with nonprofits and working with community organizing efforts to help communities improve their local food system. So that included a lot of ground level work, a lot of grassroots efforts that focused on sustainability, food access, and all of the other barriers that are associated with food. And so the food as medicine movement is very important, very dear to my heart. My grandmother, she was a diabetic. And when she passed away, she was a double amputee and also legally blind. And so for me, that is what shifted me away from being interested in medicine as far as treatment options into more public health, population health efforts. And so I'm happy to be on this panel today. I look forward to questions and just being able to share my experiences.
Thank you, ladies. As you guys can see and can tell, we have an array of diverse group of professionals, but have the same passion, the food is medicine, understanding the social determinants of health. So this is going to be an interesting conversation. I'm excited that we're able to have this conversation, one, and hear about some of you guys' personal experiences and of course, the hands-on work that you guys are currently doing. So saying that, Mrs. Shanti, so you currently work for a health plan and support your health plan's Medicaid food delivery project. So can you provide us with a little bit of background of the development, the implementation, and the success of this program, please?
Absolutely. So we have a work group for our Medicaid program, and they were looking at how to address some of the social determinants of health. And this was mid-pandemic when we started looking at this. So of course, some of those health issues and kind of barriers started to be a lot more exacerbated than they had been before. And food insecurity was highlighted for us because a lot of kids were not going to school, which meant they weren't having access to free and reduced lunch. So really, really big kind of highlight and spotlight placed there. So our health plan thought, how can we get these foods to members, and how can we kind of work on preventing food insecurity? Because we know, especially with developing youth, it just leads to a myriad of issues. So we have a previous vice president who was here who had sat in a presentation from you all, and it spoke about food box delivery specifically for maybe some of our members who were recovering from a surgery or getting home from a hospitalization. And so they said, how can we kind of use that same framework to get something done for our Medicaid members? So they made sure that we could kind of set up the same type of program. And then the team that I work with got to kind of brainstorming, who do we focus on connecting with? How do we identify what members we should work with? So we connected with our clinical analytics team and did an overlay of our service area and Feeding America's Food Insecurity Index. So in that, we overlapped our areas that were identified with at least 30% food insecurity, and then got our Medicaid outreach team on the line and had them calling families and asking if they would be open to receiving boxes. So we got pretty good feedback the first time. Our criteria for inclusion were, of course, being a Medicaid recipient from our health plan, having at least 3 members in the household who were participants in our program. And that's because it's a really, really large number of people. And as much as we want to be able to connect with everyone, resources are kind of limited. So we've got to prioritize the households that we think would probably be greatest impacted. So got our outreach team on the line. They got everything handled with our members. And then we were able to do our first delivery in November of last year. So we decided to focus on those times when students are home, when they're likely not getting those meals at school. So Thanksgiving, the winter break, and then we did a spring break box as well last year.
Awesome. So it seems like it took more than one department to be successful when it pertains to doing programs, and it takes collaborative efforts because I know one department could say, we want to create this initiative, but then you have to have other department to assist, because you guys were talking about the health education component of it as well. So it takes a collaborative effort when it pertains to being successful when trying to implement it. It sounds as if food is medicine program. And so Dr. Mary, I wanted just ask you a question. So a food as medicine program can be multi-pronged intervention to address both chronic disease and food insecurity. You have experience with chronic disease prevention and food, where you currently manage 2 federal funded grants. That research studies that have a heavy emphasis on nutrition for disease prevention. So what strategies are you currently using to address chronic disease and or food insecurity?
Great question. So with our research project, we put a heavy emphasis on whole plant-based foods. And so with our interventions, we really focus on increasing the amount of servings of fruits, vegetables, and whole grains in individual diet. We talk about everything as it relates to reading food labels, understanding and knowing what ingredients are in your foods, how to prepare them in a healthy way. We talk about seasonings and spices that can also help accentuate the taste of your foods without adding too much sodium and fat, as a way to make it more appealing to your taste. And so we explore different areas of just what's available in grocery stores, what's available that is in season, that's locally grown. We work with and partner with Food Share South Carolina, where we participate in sessions where our participants have done a chop theme class and have been given a food box and asked to make a creative meal out of it. We also, within that, we focus not so much on calories, but just making sure that folks, when they are looking at their plate, that they are following the dietary guidelines and recommendations as to how they are going to organize their meal, and making sure that all food groups are representative. And we do that and we have fun with it. In our nutrition intervention classes, they are group classes, and we found through research that group support, peer support, is very important to successful healthy lifestyle changes and finding ways to integrate different aspects of healthy lifestyle into what participants and what patients are already, how they're already living. So we are working with them to just make changes easier. And with that peer support, we find it more helpful. We also screen all of our participants for food insecurity, and those that score where we've identified that they are living in food insecure households or at risk for food insecurity. We provide a lot more information and resources to them as far as information on the SNAP program, the Senior Food Box program. We provide information on low-cost grocery stores that's actually tailored to their zip codes. We have one-on-ones with them to talk about what challenges they might be experiencing in life and do referrals to other community organizations to help support the entire person, because it is quite difficult if they are within our study and working towards living a healthy lifestyle, and maybe they just lost their job, or maybe their child is having issues and needs access to health care. And so we work with our participants as a whole, as a group, but there's a lot of individual-based efforts happening within our project as well, just based on life challenges. And so, when it comes to strategies as well that we're using to address chronic disease through nutrition, we're also exposing our participants to new foods and alternate options. Sometimes we find that, within our research participants, that they just haven't explored certain foods because they're not familiar with them or haven't been able to learn how to prepare them properly. And so cooking demos just gives an opportunity to expand that knowledge of food and how it can be prepared and how they can, make it taste good to their liking. So the supportive environment, introducing our participants to new foods, and we focus on nutrition as a way of weight loss, because nutrition is a key indicator for chronic disease, but also obesity as well is a major factor and contributor to it all relates to chronic disease. And so if we can get the nutrition right, that will promote weight loss. And that is our goal with our research studies, to help our participants eat to lose weight and to live healthier lives. And so we follow our participants over the course of our studies. One study is the dietary guidelines, 3 dietary patterns. And so with that study, we are working with participants, and they are randomized to following one of the 3 diets outlined by the dietary guidelines. And each class is organized based on the diet group that they're in. And so they follow that diet. The New Soul study is a nutritious eating with soul study, where participants have been randomized to either a vegan diet or a low-fat omnivore diet. And our classes are organized around those particular dietary patterns, and our participants follow those and receive cooking demonstrations, cooking books, and also just nutrition education as well. And so when we follow them over the course of the study to look at and evaluate their weight loss, also their dietary preferences over the course of the study. We also monitor their food insecurity status over the course of the study, as well as their blood pressure, HbA1c, also their body fat. And so those are all measurements that we'll collect and also make available to our participants and be able to show them over the course of the study how they performed as far as wanting to meet their goals. We utilize SMART goals a lot with our participants, where we give them a chance to identify what it is that they're working towards based on their where they are in life. And so with a SMART goal, it's specific, it's measurable, it's achievable, it's realistic and time bound. And so that is a way to also help keep our participants accountable. So accountability is also a big factor in our nutrition interventions, our behavioral research interventions, and our participants really need that. They appreciate it. And then of course the staff, we're an added layer of accountability as well. Because with each of our classes, we do check in with them and find out what their challenges have been, how they've been able to incorporate what they've learned over the course of the sessions into their everyday life. And then we celebrate their successes, even if it's coming off of a vacation, losing some weight, losing some inches, just having a lot more energy. So there, we definitely acknowledge it and celebrate their wins as well.
Wow, thanks, Mary. Just the information that you provided us. I mean, we can tap down and ask like 10,000 questions, but I appreciate you first giving an overview of this great research and the great study that you're currently offering to the people in this community. And it just ties into what, Ms. Ashanti was talking about, the collaborative effort and the fact that you guys are actually looking at the person as a whole person, not just thinking about losing weight, but we know that you need the data to lose the weight, but also thinking about having access, like it's the food, what types of food are they eating? And then you also tap into something about trying something new, as we delve into everyday life, we get just having our regular foods, we get accustomed to that, but then we might not have the opportunity to try something different that's actually helpful to us. And so it seems as if your research is able to look at the whole person, think about the whole totality of the day-to-day life of each patient. And so you also talked about the importance of collecting data, and you guys are collecting a lot of data. So I'm going to chime into Dr. Jackson, and decades of scientific finds support the integral role of diet in health management. You have a robust background in research that focuses on social determinants of health, and we kept using that terminology a lot today, and we will probably continue to use it. Can you provide us with some information you think is important to highlight when it pertains to nutrition, health, and access?
Sure. So I think the first thing is in realizing that with nutrition and recommendations, they're pretty standardized. We know we need to eat 5 fruits and vegetables a day, things like that. However, how that is implemented in the real world with communities that we work with varies. Several people here have talked about access. And so when you think about social determinants, it's more than just your health. It's more than just your actual behavior. It's things like access to jobs. Can you work and have a living wage? Have paid time off if you're sick or your child's sick? Do you have access to a safe place to exercise, to play? Also, access to foods that are healthy and that you can eat and that are affordable. Another thing is, I think we tend to forget that all these factors come into play. And so when we make recommendations to eat healthy, to increase fruits and vegetables, things like that, some people feel discouraged because they're not able to meet whatever recommendation has been given to them. Another thing is individual level factors, such as literacy levels, health literacy, nutrition literacy. Those are things that are different. And even though someone might understand health recommendations, they may not be able to understand nutrition recommendations because it can be a little nuanced and challenging. And I wanted to also give some examples, like my own research and experiences over the past almost 14 years. I've worked with communities where just finding things like cucumbers and carrots in the grocery store down the street, not available. So if you're teaching nutrition and trying to help people eat healthier and saying, hey, there's a store down the street, which is great, but you can't actually get the food we're talking about, then that's a challenge. Another thing is actually having a place to cook in the home. Some families have stoves or ovens that don't work. They actually don't even have a table to sit at. So I've seen that as well. And then also just the safety factor of getting to some of these stores. Some families have to rely on public transportation, go to neighborhoods that are not as safe. And then also reliance on public transportation can affect one's ability to eat a healthy diet at a set time. We all know the culture, everything's busy, fast food, quick and easy. But if you're having a challenge just having a regular schedule because you're relying on public transportation, that can affect your ability to exercise and eat healthy. So I think the biggest thing is understanding that our behaviors don't happen in a vacuum. There are so many external factors that many of which are out of our control, that are affecting our ability to actually implement what we're being taught and what we're learning. And then also it can affect healthcare providers. And that's one thing I think sometimes people don't realize. In some communities that are more underserved, availability of providers and services may not be as high or robust. I've done some work recently around telehealth and just understanding like the challenges that some FQHCs and other providers have accessing the capital to implement telehealth to serve families who can't come to the office. So I think social determinants has an impact on so many factors at the individual level, but also it can affect those who are trying to serve and trying to better their communities as well. So I think the biggest takeaway is just realize that we are not disconnected from these social, economic, and policy issues. And when trying to implement programs, take into consideration these factors, even down to your marketing materials. How are you presenting the messaging? Is it a way that's offensive? I've had some work recently where the families flat out said, we know we don't have access. We know we're not eating healthy. We don't need you to remind us. So just even thinking about how you're conveying the message, in addition to building in supports, because more than likely with our programs, we can't eliminate all the issues that are causing the challenges, but how do we support healthy living and healthy behaviors in the context of those environments until the situation improves? And that's kind of my take and how I try to approach the work is really supporting individuals and families until situations do improve.
Awesome. Thank you, Dr. Jackson. And all of us were shaking our heads while you were talking, because I think we all can relate to what you're saying. And you said something, you said, consider the factors. And we have to consider the things that like we talked about, the social determinants of health that they're faced with on a day-to-day basis. And then you also tapped into something that I really didn't even think about, was like the whole marketing piece. Like, what messages are we sending when it pertains to the populations that we're serving? So these are some great tips, and these are some things and strategies that you guys are actually providing for us. And so you also talked about the access and having the ability to be able to go to a healthcare provider or get access to those carrots and those peas. And so, Ms. Jasmine, I know your organization currently provides food boxes for patients in one of your type 2 diabetes programs. So what actions do you feel need to be taken to integrate food and nutrition into healthcare programs and other services?
Yeah, that's a wonderful question. So within one of our food insecurity programs, we do provide food boxes. And the reason we do this is because we know that in order to treat any condition, lifestyle changes are necessary. But oftentimes what happens, and as many of the other panelists have mentioned, patients will go to the doctor will recommend eating better and exercising more frequently, perhaps encouraging one or two, interventions, eating more vegetables, taking a daily walk. While this may be helpful for a select few, most people are going to need more support. So it's really about meeting people where they're at. And this is a core principle of the model at Pack Health. So in addition to food boxes, we provide recipes and education, as well as support via health coaching. And it's important to note that with this personalized method, we recognize that the education, resources, and support is going to differ from person to person. What each person needs is going to be very different. And so in order to better integrate food and nutrition into healthcare and other related programs, you really first have to identify where patients are at. So like some of the other panelists had mentioned, what barriers are they facing? Do they have physical and financial access to nutritious food? What are their health literacy levels? Can they, if they go to the grocery store, can they easily identify and find nutritious food? And if they can, are they willing to try it? And another question that I think often gets glanced over is how comfortable are they in the kitchen? If they do have the resources, do they know, if they're given X, Y, and Z instructions, they have to whisk something? Do they know what to grab for? Do they know what to utilize? Or do they not have those tools in their kitchen to begin with? And so I think asking those questions is really a first step in order to understanding your patient and understanding your population. And once you have that level of understanding, that's really a great time to really start building out and developing what resources either your health institution or your community needs. You can identify what is already existing and identify what the current gaps are. And then once you identify those things, that really helps you better tailor your program and your services to build on to what's already available. You're able to already build on to what's present in the community and really getting at the root, not all of the issues, but getting at some of the root causes of what people face, and getting them over that hump to live a more healthy lifestyle.
Awesome. Thank you, Dr. Jasmine. Sounds like you guys are doing some really good work out there in Pack Health, but you're right, getting to the root of we can't all, like we said, it's not one cure to solve this issue, but if we can just take the time out and, like we talked about, look at social determinants of health and just looking at the patient or the community member as a whole versus as a number or as just a patient, but understanding when, I sit down and I have this conversation with this patient, understanding, hey, they might have hypertension, they might be a mother a single mother that's taking care of her mother who's ill, who might not have transportation, who might have to take a bus. So there's different factors, there's different layers to people in the day-to-day lives. And so the fact that we're having this conversation is really great because it's very important to understand that the people that we work for, which are the people in the community, are not just numbers, they're not just patients, they're not just MRN numbers, but they're people as a whole. And it's important that we sit down, have those conversations, understand the research, have conversations with experts like you to say, hey, these guys have been doing this, laying out frameworks and guidelines and models that we can actually mimic. So as I mentioned earlier, the White House has hosted its first hunger and nutrition and health conference in over 50 years, you guys. So from that conference, President Biden announced a goal of ending hunger and increasing healthy eating and physical activity by 2030. So fewer Americans experience diet-related diseases while reducing related health disparities. Biden and Harris administration will focus on 5 pillars. Pillar 2 focuses on integrating nutrition and health, including by working with Congress to pilot covering of medically tailored meals and Medicare, testing Medicaid coverages of nutrition education and other nutrition supports using Medicaid Section 1115 demonstration projects, and expanding Medicaid and Medicare beneficiaries' access to nutrition and obesity counseling. So I want to pose this question to you, Ms. Ashanti. So first, what are your thoughts around this goal, and what can organizations do to get more involved with achieving this goal?
Okay, from a personal standpoint, I think that the goal is really great. It's probably long overdue, right? I think people are starting to look at the fact that so many of our chronic conditions and so many of the things that kind of go into overall health are influenced heavily by nutrition and what we're able to access. So I think it's really important, again, long overdue. In terms of organizations, I think it's been communicated by everyone on the panel here that most people know that they're falling short of some of these guidelines and recommendations. So it's our job as the people who are serving these populations to meet them where they are, meeting them physically, meaning going into the communities or making sure that we're able to connect with them after our typical business hours, because oftentimes we're not working with people who have a 9 to 5. We're working with people who are doing shift work. We're working with people that like you said, can't take off midday because of PTO or lack of coverage there. So meeting people where they are is going to be really important to kind of advancing this. Additionally, meeting people where they are in terms of their knowledge for nutrition, maybe helping them improve some of their favorite foods and kind of meeting them on the way there. And what I mean by that, of course, I used to work at Wicked Nutrition, and so we'd have so many people that came in, and they'd essentially be told that they were doing a bad job with the foods that they were feeding themselves and their families. And like, after you say that to someone, they're completely shut down. They're not going to take any of your recommendations. So I think that's another point, meeting them where they are culturally, and, you know, learning that it's like an inch by inch type of thing. In my work that I currently do at the health plan, often I'm hearing members say, well, how much is it going to cost to connect with an RD? How much is it going to cost to do this additional education? So highlighting that and prioritizing it for this particular population, Medicaid members, is probably going to do a great deal of advancing towards the goal. Oh, TQ, you're muted.
Oh, thank you. Thank you, Ashanti, for that response. But you tapped into culture, right? That's extremely important as well. That's another factor. We can talk on that. I mean, I personally can talk on that all day long, but I think you really tapped into a lot of really good points, but it's always really good to hear from personal experience. And so your personal experience was insightful. And so, Dr. Wilson, I want to pose the same question to you. So what are your thoughts around this goal, and what can organizations do to get more involved with achieving this goal?
I definitely agree with Ashanti that it's long overdue. For me, it's greatly appreciated that we are moving in the right direction here. So, you know, when it comes to organizations and what they can do, one, I would say increasing the capacity to utilize evidence-based screening tools to identify when patients or community members, or research participants, whoever you are serving, identifying if they are indeed living in a household that is food insecure, identifying and doing screenings to where, you know, you are assessing whether or not they have healthcare coverage, whether or not they are eligible for Medicaid, whether or not they are enrolled in and participating in Medicare plans if they are eligible. Those are just a couple things that they can do, because if they are not screened to identify if they are eligible for these services, then there's no way they can participate in the program. And there's some that will not know about these new offerings and where we're going. And so raising awareness is also, Dr. Jackson talked about media and promotions earlier and marketing. And so raising awareness about the availability of these programs is going to be equally important. And that's going to take, when it comes to what organizations can do, it's going to take an entire community-based approach for this. We're going to have to work with the local radio, TV personalities, people who are on the radio, who folks are already listening to. You know, coming from Dr. Mary Jones Wilson, it might not mean a whole lot, but if they hear it from, let's say, you know, we're in Columbia and lots of people listen to the Jamal Bates show, you know, if he gets on the air and announces, you know, some information and what's going on and what's being made available, people are going to listen. So identifying those key leaders in the communities that can help market and raise awareness for these programs. Organizations also have to build their capacity and their systems to be able to properly record the data that's needed and information that's needed. If they're going to be doing screenings, they have to have a way to house the results and integrate the screening process into their normal day-to-day intake or outreach program efforts. So it's going to have to be some systems changes and system improvements where if they make these, identify that these are resources that their clientele can utilize, then also documenting how they are making these referrals and what the next steps are, and maybe referring out to other organizations to support them. So raising awareness, some system changes for improvement that can help support the effort, screening tools that can help help organizations understand and learn more about and who's eligible for these services is also going to be equally important. And the other thing is just collaborating more, figuring out who you can work with in your community that can help support your efforts so that, organizations don't feel like they're a burden. Because we all know that there is a great need for these services. As Ashanti said, participants or patients are told all the time and referred to a registered dietitian, but often they don't even know how to find them, and or insurance is not going to cover it, and or it's just going to be too expensive. I work with registered dietitians and they can bill by the hour up to 100 or more just for one session. And so, as it relates to access and finances, that is a huge toll that it can take on someone's pocket if they are trying to access these services. I'll go a little further as well with the healthcare community also being a part of these efforts, and medical schools as far as their curriculum for providers and students in training. Nutrition and public health has often been organized as more so as an elective for a lot of medical schools, and or if it's not an elective, it may just be one course that's required, and they have the option to take additional coursework on nutrition and public health and nutrition or health in general. And so I think making stricter requirements for why it's important and how it contributes to chronic disease prevention, and making and increasing the number of hours that's built into the curriculum to help train our future medical professionals on the importance of nutrition and health and food as medicine. I think that'll be equally as important. I was just at in October the Teaching Kitchens conference at UCLA, and there's a big movement happening where we are now more aware that teaching kitchens are an exciting tool to use and more hands-on tool and more appropriate for helping to overcome some of the challenges associated with folks eating healthier. And there are some that are located in hospitals. There are lots of them located in communities, in local farmers markets. And so I think also realizing the importance of the hands-on training. One of the speakers basically compared it to teaching a doctor how to perform surgery without being in a surgical room. So, we're trying to teach people how to eat healthy without putting them in the right environment that will help them be able to do that. And so I think, just thinking of that, we need to support more teaching kitchens as well. And if it's not even a teaching kitchen, just organizing. It could be in a community room and buy some hot plates and some pots and pans and get to work. So there's a lot of work that can be done, but it also just starts with speaking to the right folks, connecting with the right players, and putting it as a priority. A lot of organizations every year, with their staff and or board members, they do visioning and mission exercises, and identifying what projects and what they're going to be working on over the next year to 5 years. And so putting it in writing, organizing your plans around what is coming and how you can best support. So that way you can organize how you are going to be involved. So I'd also recommend that for organizations as they are thinking about their planning efforts to incorporate these ideas into their structures.
Oh, thank you, Dr. Wilson. And you provided us, first of all, yes, you're right. You and Ashanti are right. Long overdue for this conference to take place. And I appreciate some of the tips and strategies, best practice strategies that you provided with us. And I like the idea of the teaching kitchen. And you also mentioned about marketing and awareness and taking more of a collaborative approach and building capacity. So those are very, very important factors and things to think about whenever moving towards a food as medicine program. And thank you for providing those. For the audience, if you guys have any questions for our panelists, please make sure to put those in our Q&A. So I have a question for you, Dr. Jackson. So another one of the goals from the White House conference was to enhance nutrition and food security research, including by boosting funding to improve metrics, data collection, and research to inform nutrition and food security policies, particularly on issues of equity and access, and implementing a vision for achieving nutrition science. So as a research scientist, why is this so important?
So I love data. I think it's important to have data to speak to what is happening, how programs are being implemented, how programs are being tailored for certain communities, but also it helps us to understand what works and doesn't work. A lot of times when we're evaluating programs, we get a little disheartened if things don't go as planned. But there are lessons there, and there's a lot you can learn. And so I think having this focus is so important. And for community-based programs, building an evaluation and measures early on while you're designing programs is important so that you're collecting the data that's needed to assess how well things are going throughout the work, but also so you're not scribbling at the end trying to get data. I think having consistent data across programs helps to build the strength of evidence that we need to then influence policy and to get funders more interested in the work as well. So, I've worked with some funders, and when they realize, oh, there's actually something going on, I can see with my eyes, I can see the numbers. They actually then design proposals and opportunities for communities to address whatever the issue may have been. And so I think overall collecting this data, having it is so important, especially because we need evidence for policy makers and funders, but then also when we're implementing some of these programs, especially best practices, we may not implement them as they're written. We may have to tailor and adapt for our communities. And so understanding what has been adjusted or adapted is important. And then understanding how those changes may have impacted the success of the work we do is also important. So I'm all about collecting as much evidence and data as possible. And it doesn't have to be, a 50-page survey. It could be something small, working with your resources, working with evaluators in your area, but just having something, a component of the program and the work you're doing focused on evaluation as well.
Awesome. Thank you, Dr. Jackson. And I used to be like a boots on the ground, a lot of boots on the ground when I did a lot of my work. But then as I got more into the work that I currently do now, I learned that policy and advocacy has a huge impact on change and also data and research. So in order to validate your work or to validate change, you have to use data, use metrics, and also that can help change policies. And so I've had to shift on how I looked at change and understanding that advocacy and policy and research has a huge impact on the work that we do. I mean, those that are foot on the ground, we see it on a day-to-day basis. We meet with these patients or community members, we hear their story, but people in the Congress or people in the White House or people that are signing bills and sponsors and everything like that. So it's very important that we are mindful of the data, the policy, and advocacy. Thank you for sharing, Dr. Jackson. So, Dr. Moore, I got one last question for you. The food as medicine approach to health management challenges the construct of conventional medicine, which relies primarily on technological medical advancements to manage health and disease with pharmaceutical drugs. Both approaches seem necessary and important. So from a programmatic perspective, how do you combine both approaches?
That's a great question. So we know that having a chronic condition can affect every aspect of a person's life, whether it be social determinants of health, such as financial, also just day-to-day, how they're feeling. And so both aspects of management are crucial. And so we design our programs with that in mind. We do extensive research to ensure that we have an understanding of what current patients are experiencing, as well as to ensure that all resources developed are backed by current evidence and are addressing those gaps, as well as making sure that when we are developing our programs, especially our research-based programs, that the metrics that we're selecting to to be utilized are capturing data that either can close gaps within the research sphere or that can provide an additional and more in-depth clinical picture of what exactly patients are experiencing as today. And so we utilize validated metrics such as diabetes distress and USDA food security questionnaire for our type 2 diabetes specific food insecurity program to get a piece of that clinical picture. But in addition to that, we also train our health advisors who provide our coaching to lead a discussion with their members to ensure they're able to address any questions a member has and provide appropriate resources. So making sure that once those barriers are addressed and identified, so if someone doesn't know where the closest grocery store is or where the most affordable groceries, if there's a farmer's market nearby, our health advisors work with them to ensure that the resources being provided are what they actually need. And in addition to that, we also utilize SMART goals on our weekly calls. So when members have their weekly call with their advisor, they'll use motivational interviewing as well as prompting to help set that SMART goal, review barriers to that individual goal, and identify additional items, whether it be food or ride provision that they may need, and help them find the resources within their community to get them what they need. And the biggest thing that we always emphasize is we are helping members grow and utilize their toolkit. They had tools prior to coming to us. They probably just didn't recognize what those tools were. So they were most likely on medication and they had a care team. Those are tools within a patient's toolkit. They may just not know how to use them. So we start with disease understanding and understanding of what their tools are. And then we add on when we're designing our program. We add on with food, with education, with resources. And at the end of the day, our main goal is to make sure that patients feel that they are able to be a self-efficacious patient, that they're able to advocate for themselves, that they're able to manage their condition on a day-to-day basis without feeling overwhelmed or like they're kind of sinking with all of these different guidelines and regulations that they hear about, and that they're able to be a fully functional and have a very high quality of life despite their chronic condition.
Awesome. Thank you, Dr. Moore. And I think it was, and I wanted to ask you that question as a pharmacist, and, because of conventional medication versus food as medicine, I think it's important just to understand the importance of both, because sometimes people are just like, well, I don't need to take my medication because the doctor said eat more of this, or, I'm not going to eat healthy because I'm on medication. So there is an important need to understand the importance of conventional and also, non-traditional type medication. And I appreciate you providing your expertise on that question. Thank you so much. Ladies, I appreciate you all. You guys are a wealth of knowledge. I think I can have a webinar with just each of you individually, and we just have a wonderful conversation. I wanted to go to our Q&A. I have 2 questions, and I'm going to open this up to the panelists. This is a really good question. It's from Melissa. So what roles can HBCUs play in addressing these issues? And I'll just open it up.
I can start with that response. So I guess I would also like to know where Melissa is located, if she can drop that in the chat for me.
She's in South Carolina.
As it relates to, awesome. Okay, so I can tailor my response as well. So Melissa, I would also say just partnering with other research institutions, Research One institutions, collaborating on different grant projects can be key. The other thing is also, I'm USC all the way, but I also support Clemson in their efforts as well. They have the Clemson extension where they have agents located in just about every county that they serve, where they provide expertise and assistance with researchers, educational communities on nutrition and agriculture. And so they have a wealth of knowledge and supportive programming as well. So reaching out to the local Clemson Extension agent for your county would be helpful. The other thing too is incorporating these goals and interests into the existing staff structure at HBCUs. So if wellness is important, if food and nutrition and health is important, then, look at some of the initiatives with other universities. I'll say USC is one. We have an office called Healthy Carolina, where we support the overall health and wellness of our students, faculty, and staff. And so some of those programs look like a campus community garden, referrals for a campus food pantry, referrals and sessions and classes that faculty, staff, and students may access that involve nutrition education. There is also with our Student Health Center that is accessible and by faculty and staff as well, where they also have a teaching kitchen. And so there are lots of efforts that you can organize around supporting the food as medicine movement in different ways for all members of your HBCU community. So feel free to reach out to me if you would like some connections as far as efforts that are already underway at other universities and even USC that you might be able to mimic and talk more with some staff about and how you might be able to implement that at your HBCU. And I can pass it to you if there's anyone else interested in answering that question as well.
Thank you, Dr. Wilson. Go ahead, Dr. Moore.
Thank you. I also think, the HBCUs, their student population, especially their graduate student population, is a phenomenal resource. With pharmacy schools, medical schools, these are obviously our future doctors and what have you. So utilizing them, oftentimes there are many student groups within different health science schools within universities where they go out into the community and they're always, looking for ideas and how to better engage with their community and how to really improve health on a local level. And so, reaching out to either registrars or the student activities board and things like that can really be a great way to make those connections, but also get some more resources into the community as well.
Thank you, ladies. I have one more question. So this question is from Ms. Greta Watkins. How can health and wellness and fitness professional coaches best support this effort? That's a good question.
So I'll start. So with our research project, we actually work with fitness professionals. We bring in personal trainers, licensed professional counselors as well, yoga instructors. And so in our goal to support the whole person on their journey for a healthy lifestyle, we bring in personal fitness instructors to do sessions with our participants to show them the benefits of exercise and how they might be able to incorporate it into their day-to-day life. Licensed professional counselors, they talk about with our participants emotional eating and stress eating and how their mental health impacts their ability to eat healthier or not. And then yoga instructors, we talk about stress management and relaxation. And so I think the best thing for, health coaches and fitness professionals is to just identify research that's happening and just be open to collaborate, be open to serve as a consultant on some projects, making your services known. And so, those are the type of people that we seek out for our projects. And so just maybe even just visiting your local healthcare providers' offices and local community organizations and being part of these local coalitions. So for example, we have Holspire. I serve on the board of directors for Holspire, but the goal is to have a Holspire chapter in every county of the state. So just looking at what local collaboratives are in your community and how you might be able to participate, because this is where you'll make those connections with people who are like-minded and learning about opportunities of how you can best support the local efforts without trying to reinvent the wheel just learning more about what's already being done and how you can fit into that. So that would be my best suggestion on how to get more involved.
Thank you, Dr. Wilson. So Ashanti, did you want to have a closing remark?
Yes, at least supporting what Dr. Wilson was saying. For those health and wellness professionals, continuing education. So there are always new trainings, there are always new curricula, and I think staying on top of that is going to help, especially knowing that this is being kind of highlighted for 2030 or for Healthy People 2030. There are likely going to be supporting trainings and information and all of that, which likely are going to be free of charge or at reduced cost. So, you know, sometimes being able to afford those additional trainings and certifications is a barrier, but often they have ways to support them because they're trying to push new concepts and ideas. So continuing education and looking for free resources to do so.
Very, very, very good point. Ladies, Dr. Moore, Dr. Wilson, Miss Ashanti Jefferson, Dr. Jackson, you guys have been a blessing to all of our hearers. And I want to say, personally want to say thank you for providing your expertise. We are at the top of the hour. It went by fast. Time flies when you're having so much fun. Like I said, we can have a conversation with each and every one of you. But we thank God for each and every one of you for providing your time and your talents, because you all are very talented, and we appreciate all the work that you currently do. Thank you so much. And thank you guys for joining. This will actually be recorded, and we will be sending this out on our LinkedIn site. Thank you guys. Have a wonderful day.
Thank you.
Thank you so much.
Stop.